This is a hybrid program. Thank you for joining tonight for our Empowering Parkinson's Caregivers program presented by Meribeth Brookman, PTA. This seminar will address common concerns and issues that arise throughout the stages of the disease. It will also outline the local resources available for patients and caregivers, safety concerns around the home, and fun ways to be involved in your loved one's care team. I'm going to give the floor over to Meribeth now. Thank you.
I've been in the field around 4 years. I started my journey in outpatient ortho, and I wanted nothing to do with neuro because I was like, in school, it's super complicated, confusing, frustrating, don't want to do it. And I was in my last clinical rotation at JFK, and I got to treat under a clinician that was Power Move certified, which is what I have. And I absolutely fell in love with the difference that we could make in our community. I went on to Clarkson in Nebraska to further my education yet again. And I had a capstone project of creating community resources. And what I did is I said, Piscataway has no local, thank you so much, no local Parkinson's classes. We need to do something about that. And so it took me about 6 months, and officially 2 years ago, going on like 2.5, in April, I started my first Power Moves class for my community. And then since then, it's been, all steam ahead. I recently joined a company called Synaptic Rehab, which specializes in neuro in general, especially Parkinson's, because it's a bunch of clinicians who have just a love and a drive to treat that community. So I have a bunch of information for them as well, because it's a bunch of clinicians like me that have LSVTBig and Power Moves and just love making a difference in their community. So she already read the objectives, right? My goal is to give you guys some tools that you can use around the home and just in general life of how best to promote safety and get involved. So I'm not going to bore you, right? You guys have probably all been to a bunch of doctors or sat through a bunch of lectures and statistics about what is Parkinson's. It's a neurodegenerative disease that affects those dopamine producing neurons, right? Which means our movement becomes impaired over time, that no-go signal in the brain becomes impaired, and we kind of don't function as smoothly anymore. And it leads to a host of symptoms. So going a little bit more in depth to these symptoms, we're going to talk about the diagnosis progression. So first things first, the first 10 years, most patients don't even know that they have Parkinson's, right? Because there's a bunch of symptoms that appear that seemingly have nothing to do with movement disorders, right? GI issues, insomnia, anxiety, depression, those are all things that we have, right, in just regular life. And if you think about it, you don't go, this is Parkinson's. You go, oh, I'm anxious, or oh, I'm having a rough time, or oh, I'm not sleeping. And then 5 to 10 years down the line, those movement symptoms appear. And that's when we go, okay, we need to see a neurologist. We need to get a little bit more involved. That's when those big ones appear. You might have heard bradykinesia and hypokinesia before, right? Bradykinesia is slowed movement. Hypokinesia is little movement, right? Those are two of the most common. We also have tremor, which everybody is like a hallmark sign for them. Rigidity, which is that trunk rigidity. Freezing, which is that like loss of ability to initiate movement. Fascination, small steps, and balance issues. So even though these are like the most common symptoms, every patient with Parkinson's is a snowflake. You will never meet two that are exactly the same. You probably hear that from everybody, right? It's just, oh, it's the snowflake disease, because everybody presents so different. I have patients all over the spectrum. I have patients where you wouldn't know, they never freeze, they don't have balance issues, but they have a tremor. And they have so many of these non-motor symptoms. And then I have patients who have horrible balance issues and very severe tremors. It's all across the board. So here is really scary. It is scary for your loved one, because they're getting handed this diagnosis that feels like a death sentence. And it's scary for you because you're like, what am I going to do? How do I support this person that I love walking through this? It's terrifying. And that's when you have to work on giving each other a lot of grace, because your loved one's most likely going to get very upset and some anger is going to come out, and it's not meant to come out on you whatsoever. It's just processing this disease, because often people treat it like it is a death sentence, when in reality, people go on for years and years and years and have amazing quality of life, right? With the right medication, with the right balance of exercise. My lovely neighbor has been diagnosed for over 20 years, and she's out there working in her yard all the time. She's out there doing everything under the sun, and it's an amazing story to see. So after we see the movement symptoms, right, we go to a neurologist. That's when we get the diagnosis. Here comes another one of the most frustrating parts of getting diagnosed. It is the medication trial and error, because it truly is guess and check math, which is super frustrating. The doctor's going to give you a set of medication that they think is the best, and it might not work at all. It might cause horrible dyskinesia, which you guys have probably heard of, which is that uncontrolled movement. And that makes patients very upset because they do not know how to function. Sometimes they have worse quality of life than before the medication. So they're like, I don't want it. I just want to stop. I just want to go back, which is very common. That's when you guys have to practice a little bit of patience, and you guys have to be the ones that say, hey, this will figure itself out. It's going to take time. We got to go back to the doctor. We got to give it time. The other strategies we do is we make medication journals, right? We do timings. We go, okay, we took our meds at this time. We had symptoms here, or the medication weaned off here, and you make a list, right? Because when we go to those doctors, either your loved one is having memory issues or you are overwhelmed with the amount of information that you have to recount to the doctor. So you need to have that written journal to hand them, right? And they will figure out the medication timing. They will figure out the type of dosage. Not everybody is a candidate for every medication. Not everybody is a candidate for slow release, everything like that, right? They have to figure that out. Every patient is a snowflake, but it's going to take time, and it's super frustrating. After we get diagnosed, right, and they figure out a little bit of the medication, I want everyone to go to speech. Obviously, I'm not a speech language pathologist. I love them. They are amazing. Right? You think, oh, it's just about like the talking levels and stuff like that. No, one of the leading causes of death with Parkinson's is pneumonia, because we're not able to swallow properly, right? Because everything gets smaller, including swallowing. So you go to speech, you go, hey, we're going to go for baseline testing. That might mean we go once, they teach us exercises, we're good. We check in every year, 6 months. It really depends on the patient. But you have those strategies and you keep practicing them the whole entire time, right? Because that is for quality of life. And that's you get to be the person nagging in the background of, hey, did you do your speech exercises today? Or hey, let's do them together, which I'll teach you some fun ways to do that later on. And then getting into PT. So many patients that get sent by the neurologist to me are like, there's nothing wrong with me. I'm completely fine. This is a waste of my time. And I'm like, okay, let's try some stuff. Let's check some things out. Let's see how we do. And then they go a few weeks down the line, they're like, yeah, I did not realize that was one of my problems, right? And you may see it. You guys are going to see those deficits before the patients are going to see them, because you live with them and you watch them and you know what their normal is. But part of this is to say it's not your job to go like, this is your problem, right? We lovingly get them to the person that can best help them learn strategies to cope with it. And honestly, sometimes it's hard to listen to your loved ones telling you something, because in their mind, right, you might say, hey, you need to take bigger steps. And in their mind, we are walking normal, right? But our perception of normal has changed. So getting them to someone who can point out and videotape and show them bigger amplitude movements can make a world of difference. Now we are to living with Parkinson's, right? We are prioritizing exercise. Exercise is medicine. It is life, right? Exercise is part of your routine. Recommendations is minimum 2.5 hours a week. Minimum. We'll go into that a little bit more later, and I also gave out a brochure on that. It covers a few different domains, but exercise can be a lot more than just lifting or going for a walk, right? It can count as yard work. It can count as cleaning. It really depends on what you're doing. But almost all of us are getting up and moving at least 2.5 hours a week. And if we're not, we need to fix that. We should not be sleeping all day long. You also need to build a solid support team. We are all part of a team. All of us, family members, PT, OT, speech, we are a team. It is our job to support, right? That person's living with Parkinson's. And then we're going to continue to live as independently as possible. That's always my goal. I want you to stay as independent as possible for as long as possible. Nobody wants to rely on somebody else, right? And so we want to help our loved ones. Sometimes we want to help too much. Sometimes I'm over here yelling at caregivers, go, don't help them up, let them do it. Don't tie their shoe, let them do it, right? Because they need to practice those skills to maintain them. We want to help, sometimes we can't. Sometimes we have to stand back and say, you got this, I'm going to support you from afar. So a little bit more in depth of these symptoms, right? We talked about bradykinesia before, slowed movement, tremor, I'm sure everyone is aware of. It's that shaking, rigidity, trunk rigidity. I yell this in all my classes constantly, and all my patients could probably quote it back to you and tell you how annoying I am. Rotation, rotation, rotation. Trunk rotation breaks rigidity. That's one of the biggest principles of LSVT and power moves is rotational based movements. You'll hear them yell twist all the time. That trunk rigidity gets broken up by rotation. So those are the movements that we promote a lot. I literally yell it all day long in my class. Freezing. That one sneaks up on us a bit. And you'll notice it a lot when people are approaching chairs, negotiating obstacles, often going through doorways or approaching color-changing surfaces, which we're going to talk about in a little bit. And it's your job to identify those triggers, tell PT about it, because one, they'll practice that exact scenario and help you break it or teach you strategies to break it. The other thing is learning how to help your loved one break it through weight shifting, right? In LSVTBig, we do the S's. So frustrating, so many S's, but it's stop big, stand big, start big. So you have to learn how, oh, you feel it coming on. We're going to stop, stand in place, take a breath, right? When we get anxious, it's going to make that tremor and that freeze worse. So we take a breath and relax, and then we weight shift and we start big. The key to breaking a freeze is unweighting one side of the pelvis in that weight shift, right? So taking that step will break it. Shuffling gait, I'm sure you're all aware of that one. That's those little steps that almost look like we're shuffling on the floor. Balance issues. This is a big one. Hypomemia that a lot of people don't know that I have to tell family members about, because a lot of people, I told someone about it last week, was like, my dad's always angry. Why does he always look angry at me? I'm like, he's not angry. He's not angry. We just deal with this masked face where even the muscles in our face go through that hypomobility where they're not moving as much, right? So it becomes like a mask-like appearance. Dystonia, those muscles cramping, also known like you'll see restless leg a lot and stuff like that. Micrographia, where the writing gets really, really small. Dysarthria and hypophonia, right? That speech gets lower and lower and lower, and we might have some slurred motion, some slurred speaking, which is why speech is so important. Dyskinesia, which we talked about before. Stooped posture, that forward flex posture. Trunk rigidity, because clearly I thought that we needed to say it again. Decreased arm swing with gait, which ties into that trunk rigidity because now we're no longer rotating. And difficulty with bed mobility and fine motor skills. So these are the stages. I'm sorry that the video is blocking one of them. The first stage, right, we only have symptoms on one side of the body. You may see the posture and the walkings a little bit affected. Stage 2, the symptoms start to affect both sides of the body as the symptoms progress. We're going to see a lot more postural instability, but people can still live alone independently. Oh, thank you. Stage 3, it's a lot more falls, a lot more balance dysfunction. Motor symptoms get worse, but we can still live alone. We just might have difficulty with driving. We might need some help around the house, and we definitely are modifying the environment at this point in time. 4, the symptoms are fully developed and pretty severe. We're using an assistive device to walk all the time and to stand safely, and you need help with those activities of daily living. And then stage 5, this is where a lot of people not able to get out of bed, stuck in a wheelchair, and they need around-the-clock aids or care. I can tell you, now that I'm in home care PT, I see people from stage 1 to stage 5. I have patients in all levels. And you know what? The same principles do not change. I'm still doing forced high-intensity exercise with stage 1 and stage 5. It may look a little different, but You can help and work with every single stage. And it's your job to make sure that your family member or loved one stays motivated to keep working, because even at stage 5, we can fight to get back some independence, okay? So what is your job in these stages? Stage 1, we got to get as educated as possible, right? Which you probably have all already done, because if you're here, you already have been looking into things. We're building a good support team. And my absolute favorite is finding local classes and activities. Stage 2, right? That's when the symptoms progress a little bit. We're evaluating the home. We're trying to promote as much independence as possible, but prioritize exercise. So we're that little voice going, go outside, or let's go for a walk. 3, we're doing a lot more of going to PTOT and speech, right? That's when things have gotten a bit worse. We're having a lot of trouble around the home, having a lot more falls. So we still want to maintain independence, but we're going to need a bit more assistance, and it's your job to kind of jump in and give what they need, but not too much. You're still trying to make sure that they do as much as they can by themselves, as long as it's a safe activity. Stage 4, we're learning from therapies the best way to protect, right, with balance issues, and the best way to modify, and how to walk with assistive devices. A lot of the times I see clinicians throw patients on the most assistive device possible, and I'm like, whoa, they don't need that. They don't need that. I'm like, let's get them back to a cane. Let's give them as much normal motion as possible. So be very selective of who you put on your teams. Make sure it's somebody that has a lot of experience with Parkinson's disease and has seen patients and aligns with your goals, right? If there's a person that just like, we're just trying to give you balance and get you out of here, that's not who we want. We want someone that's really dedicated to making sure they're part of your team and they're keeping you as independent and as safe as possible. And same thing at stage 5. We're prioritizing independence, but we're going to have to learn a lot from PTOT and speech on how to do and help with some of those ADLs, right? Therapeutic Dream Team. I am part of PT. We work on restoring amplitude of movement, mobility, balance, increase independence, and try to return to prior level of function. I'm sorry, sometimes I speak in shorthand, as much as possible. OT, they're going to do a lot more ADLs and IADLs, which means activities of daily living and independent activities of daily living. So they're going to work on fine motor coordination of eating, right? Brushing teeth. They do a lot of like reteaching shower and bathing mechanics and stuff like that. And they're going to teach you guys as much as they're going to teach the patient. All of us, our job is not only to treat the patient, but to also work with the families. We are part of a team. I'm going to say that probably a billion times. We are part of a team. And then speech, right? They're addressing the voice concerns, they're evaluating and improving swallowing mechanics, which is a huge one, and creating that baseline of the voice assessment. So environmental complaints, which is one of my favorite things. Stairs. We need a safety railing. We might not need it now, but we're going to need it in the future. Because when we carry stuff upstairs, that is like 90% of the time my patients come in and say, I fell. And I'm like, what were you doing? And they were like, I was carrying 16 objects up the stairs. It's going to happen. So we want to have a railing. They might not always use it, but we need to have it for the future. The other thing that people are not always aware of is floor surface changes and color changes can trigger freezing and falls. So that means going from a carpet to a wood floor, going from carpet to a big one is going from the bedroom carpet to the bathroom tile. A lot of people trip on that door frame, and it might be this thick, right? That little threshold to the door might be this big, but people will tell me it feels like it's this big, right? So that's kind of hard because you go, I'm not going to change my floors. Some people do. Some people end up modifying, but that's something that you take to PT and you go, this is what's causing my problem. And we're going to go find a color changing surface and we're going to teach you how to work on breaking that. A big one is night lights on the floor. A lot of falls happen at night when we're getting up to use the bathroom. So there are night lights that are motion activated. So the second your feet hit the ground, the light goes on. A lot of people don't want like the bright night lights or lights on outside. That's fine. I get it. I don't like sleeping in the light either. But having night lights plugged in that are motion activated can prevent a lot of issues, right? Vision is like 90% of our balance for a lot of us. We rely on vision so much. So you take that away, and you add balance issues at nighttime running to the bathroom, it is a bad combination. Not good at all. So I strongly advocate for nightlight. Laundry bag and dish tray for stairs is actually something my patients wanted me to add because it is something that has led to falls for 2 of my patients, right? So we talked about getting a laundry bag because carrying the basket up the stairs, not working, right? Our eyes cannot see the stairs. We're not clearing the foot enough. That's going to lead to a fall. So having some kind of modification for carrying stuff so that they can still do the work instead of you guys is going to be a big difference. And carpets. Carpets are great. They're lovely, but the really thick ones can cause assistive devices to get caught, can cause toes to get caught because often we do not pick up our feet enough. We do not clear our toes. So we want to make sure that we either change the flooring. I know that horrifies everyone. Not everybody wants a shag carpet in their house. Or we'd spend a lot of time working on stepping strategies and awareness. So when it comes to bed mobility, these are things that you need to remember because you are going to have to remind your loved one. Momentum is our best friend when it comes to bed mobility. Utilizing the power up for sit to stand, which is another momentum that I'm going to teach you. And big walking principles, right? Which we will go over later.
See me? Foot up. Big twist to our side. Pants. Push up, pull that elbow through. Yeah. So it's this move. Push up, pull through. It's stacked and packed, elbow under shoulder. Yeah. Feet go off, up to sitting.
Once you get the legs off the bed, that's 60 to 70% of the weight. So if you can get them to swing the legs off the bed, you're golden, right? But we use that big twist to get over. So we're using, right? We're setting up one of the legs so we can get our hips over, big twist. We are planting the hands, getting that elbow stacked and packed under the shoulder, and then throwing those legs off because that's 60% of the weight. And then they can just lever themselves up, which is something, again, you'll learn when you're going to PT with your loved one, or they come to you, whatever it is, they're going to teach you these strategies. So this is me and one of my patients. He wanted to be a part of my presentation, working on using the power moves to roll in bed. So I'm teaching him how to use these floor power moves to roll all the way from side to side. Now, I wish I had a video before we did this, but rolling is very, very hard for him, and it takes a very long time. This is 30 seconds quicker than it would take him to roll to one side. And this is the last one where we are again working on bed mobility. We are working on pressing up from the floor. I love the floor because if you work out on the floor, there's nowhere to go, right? There's nowhere to fall from the floor. And we're working on using that big amplitude to turn over, back and forth, trying to work on that transition. It's a good showing that hesitation. Yep, and then he really locks in and he uses momentum to get over. Perfect, and then he uses momentum to get back. I wish you could hear it because he's cracking jokes the entire time. This is often the most fun that I have with people. But these are all strategies that when you go to PT, you will learn, right? These are things that we can use from day to day that makes getting around in bed so much easier. Working on that explosive big momentum motions. It's okay. Momentum is king. As you saw in the video, is a really good example of when he didn't use momentum, he could not get over. And then if you would have heard the video, you would have heard that cue of big arm swing, which is what you guys are going to say all the time is big. You're going to get so annoyed of the word. Sometimes I get annoyed of the word. I start saying large and magnificent and just really getting creative. Legs are 60 to 70%, right? If you can get their legs off, whether it be you pulling them or them throwing them, it is very easy to sit up in bed. Explosive arm twists and shoulders stacked and packed. Okay, so the power up for the big sit to stand. One of the biggest issues that we see is something called retropulsion, or the loss of balance backwards. And it's very, very common when we stand up from a chair that we don't have the momentum to get up, or our toes come up, we fly backwards. So there's something called a power up. It is not just useful for someone with Parkinson's, it's actually useful for a lot of the elderly population or anybody who has a balance issue or a leg strength issue comes in handy. So it is a big reach forward. What you'll notice is as I reach forward, my hips leave the chair, right? Nose over toes mechanics. And then once you're here, you throw your arms back and you're up. So they might need a few rocks. You might need, it might be a 1, 2, 3 situation where you do bigger, bigger, up. Or it might be in arms where we use the arms to help us rock. But just simply cueing them to keep that nose over toes is going to help them fight that retropulsion episode and stay up nice and steady. I love power ups. I use them a billion times a day. They're magical. Falls happen. Falls is like a dirty word. No one wants to hear it. Falls happen. Falls happen all the time, right? When we're 2, when we're 8, when we're 15, when we're 80, all over the map, they happen. One of the times you will notice them the most outside of those environmental triggers in your homes, when we're super fatigued, you're going to see a fall can happen. Our movements get sloppy. We're not aware of picking up our toes. That's when falls happen. When we're not aware of our environment or negotiating unpredictable surfaces, right? Sometimes that visual perception is impaired and you might not see as much that the ground's going down. That's when we have to be very conscious of letting them know, hey, let's scan the environment. Let's see what kind of things that we see before we go out walking, right? Or if we're going down a hill, maybe that's time we go, hey, let's slow down our steps a little bit. Let's take our time, right? And you can blame yourself if you want. If that works better, you can say, hey, I feel a little unstable. I'm going to take my time, and that's going to slow them down. Falls happen all the time. I don't know anyone that hasn't fallen once in their life. That'd be crazy, but we have to be ready. So I have some fun videos of me working on fall training in PT with one of my patients. So this is him learning fall mechanics, because the one thing we do not want to do when we fall is straight arms, right? If you notice, he's got his arms bent. He's landing on that blunt portion of his arm. I'm going to play it one more time. Because when we fall with straight arms and outstretched hands, it's something called a foosh, or a fall and outstretched hand. That's how we fracture our wrist, right? Again, not just with patients with Parkinson's, with all of us. You'll see a lot of people come in with this like big cast on. It's because they fell like that. So practicing that mechanics and going over, okay, blunt portion of our arm, that's what we want to fall on. This is us working on falling backwards, right? So he's learning that tucking his head as he rolls and being able to recover. If you've noticed, I have way too much fun when I work. I do this kind of stuff all day long. It's amazing. Yep, and he's learning how to initially tuck and roll. And the last one is possibly the most fun one. Because the last one is the most fun because you get to see me push him. So that is a more realistic picture of falling than the other two, right? He's getting shoved from behind holding something, right? Because his biggest issue is he's like, I carry stuff up my steps, I fall, and I just don't know how to protect myself. So I said, cool, we're going to fall holding something and we're going to see what we do. Because stuff can be replaced, we cannot, right? So what do we do when we're falling holding something? We get rid of it. We throw it out of the way. Stuff can always be replaced. Our bodies and us cannot. So this one's really cool. He was a good sport about it. Not everybody wants to come in PT and get shoved on the ground, but he was like, let's do it. Floor to stand transfer. I don't know if everybody at home is going to be able to see it, but you guys are going to be able to see it. Getting up from a fall. We need to know how to do it because falls happen. We need to know how to instruct for it. So my favorite thing to do is use a chair. Okay, so if your loved one is already on the ground, right, we can use, as you saw before, that press up. When they're here, if they're having trouble getting up, you are helping with the hips, right? Legs are 60 to 70% of that weight. If you can cue and help at the hips, they're going to get here. From here, we're finding the chair. This is our best friend. We use that big weight shift mechanic to rock back, get one leg up. From here, we can get the other leg up and stand up. If we want to safely get down on the floor to exercise, it's the same deal. Easy, 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 easy. And it is the safest way to get up and down when we have balance concerns. The other way, so say someone is much more stable or not falling, they're just working out on the ground, they're going to use that big rock back and step, which is one of the power moves. From here, we're going to take a second. We're going to adjust. I don't know if I can do this in heels. We're going to find out. And they're going to press up, right? Same exact mechanics as in the chair, but a little bit more balance is required. Floor to stand transfer. I don't know if everybody at home is going to be able to see it, but you guys are going to be able to see it. Getting up from a fall. We need to know how to do it because falls happen. We need to know how to instruct for it. So my favorite thing to do is use a chair. Okay? So if your loved one is already on the ground, right? We can use, as you saw before, that press up. When they're here, if they're having trouble getting up, you are helping with the hips, right? Legs are 60 to 70% of that weight. If you can cue and help at the hips, they're going to get here. From here, we're finding the chair. This is our best friend. We use that big weight shift mechanic to rock back, get one leg up. From here, we can get the other leg up and stand up. If we want to safely get down on the floor to exercise, it's the same deal. Easy, 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 easy. And it is the safest way to get up and down when we have balance concerns. The other way, so say someone is much more stable or not falling, they're just working out on the ground, they're going to use that big rock back and step, which is one of the power moves. From here, we're going to take a second. We're going to adjust. I don't know if I can do this in heels. We're going to find out. And they're going to press up, right? Same exact mechanics as in the chair, but a little bit more balance is required. So how we make PT fun and effective, right? This is the coolest part is you guys get to be involved in every step. So all this stuff that I do with people in clinic, you get to do it at home, which might be terrifying and unfun to you guys, but I think it's the best. And you just get to see some of the fun we have. So this is trunk rotation baseball, right? I told you I love trunk rotation. It breaks rigidity. So he is working on hand-eye coordination and he gets to hit me with the bat. That was like the selling point of why everybody wanted to play trunk rotation baseball. They get to hit me, take out their anger. And what you cannot hear is we're actually playing a cognitive game while we do it. So every time I throw it, I'm naming a random letter and he's naming something that starts with that letter. Obviously, again, I have too much fun. This is bed mobility basketball. So we are working on going from our stomach to tall kneel with hand-eye coordination and tall kneel balance, right? We have that trunk stability that we have to fight for when we're in tall kneel. Imagine how great everyone would do if their family members were also doing this kind of stuff at home. It'd be magical. It doesn't have to be you. It could be kids. It could be spouses. It could be grandkids in some of my patients' case. And I have some examples of like less aggressive activity that you can do with your loved one at home. But PT can be a lot of fun. I want you to advocate to get your loved one into it. Yep, and this is just another one working on that mobility and that big power step that we talked about before and some hand-eye coordination. I clearly absolutely love, you'll see here, I brought some of my toys. I love sensory toys. I love anything that makes PT a little bit more fun because I think it can be not boring, but you know, needs a little spicing up sometimes. So my ramen noodles, which are on the table, are what we're throwing. They're a sensory toy. They're hard to throw, so they require a lot more amplitude to get up, and they are hard to catch. So why exercise? Exercise is neuroprotective. These are the reasons that you're going to use when you advocate for it, because a lot of people do not want to go. They don't want to work out. They don't want to go to PT. Why do we have to do it? It's neuroprotective. It protects those residual pathways. It promotes neuroplasticity. So it creates new pathways in the brain, right? It helps us maintain those motor functions. And it can also affect the non-motor symptoms. A lot of people suffer from GI issues like constipation. A lot of people suffer from sleep issues. Exercise can work on those, right? The more we move, the more mobility we got going on in our GI system. The more time we're fighting gravity, gravity's working on that issue for us. So again, I wrote a little bit more reasons of why exercise, because I'm huge advocate for it. We're trying to maintain as much mobility as possible. We're trying to work on motor and non-motor symptoms. We're hitting that 2.5 hours of activity a week that we need to, whether that be together, whether that be you go, hey, go for a run, I'll see you in like 30 minutes, just make sure it happens. So what are the exercise recommendations? We have to hit a few things: aerobic activity, strength training, balance, agility, multitasking, or something we call dual tasking in PT, and flexibility. So the cool thing about doing programs like Power Moves, again, I told you I'm a little biased. I love Power Moves, is it hits every single domain. So when I run a class, we touch every domain in every class. There are a lot of activities that you do not think about that encapsulate all those things. So you don't have to go, oh, okay, today I'm doing aerobic activity, I'm going to go for a run. Oh, tomorrow I'm going to lift weights. Thursday I'm going to stand on one leg. No, we can pick activities that actually work on all of them at once. Flexibility, everyone goes, I'm just going to stretch, right? I'm just going to stretch. But there's something called dynamic mobility and flexibility, right? Which we can stand and stretch all day, but we're not going to maintain it. But if we strengthen into those new available ranges, our body will maintain it. So we follow up that stretching with strengthening into those new available ranges. So what is the best and most effective exercise? It is a trick question. It is whatever exercise your loved one likes to do, right? Because if someone hates running and I tell them to go run, not going to happen. I have patients that play pickleball a few hours a week. They love it. They get so into it. They're running all over the court. Amazing. It works on balance, right? It works on hand-eye coordination. It works on that aerobic conditioning, strength training, everything, because we're weight bearing. Great. I have patients that want to bike. Cool. I have patients that play badminton. Some people take pool exercise, right? And water aerobics, water kickboxing, anything you like. Cool. That's what you do. And the most fun part about this is if you can pick an activity that you guys both enjoy, like my one patient who likes pickleball, it's something him and his wife do every single week. That's a few hours a week that they go, they make each other better. He still hits all of his domains and he does his 2.5 hours of exercise and they have a lot of fun. It's a bonding activity. So fun ways to get involved. Like I talked about before, these are some of my favorites. Some are mine and some are actually added by my patients. Loud Uno and Loud Go Fish. I came up with this in clinic. We got a decibel meter, a free app on our phone that can rate how loud we're talking. We put it in the middle of the table and there's 4 of us yelling, go fish, into this table like lunatics. And it was so much fun. So much fun. He had a blast. We as a clinic had an absolute blast. And you can do that at home. It's so easy. The apps are free, right? A lot of them are free. And you just need cards. And then, cool, I worked on my speech for the day. I did my voice exercises. I hit that rate I was supposed to hit, and I had fun as a family. Rock band was something my patient came up with because he got tired of his voice exercises. So him and his daughter play rock band every night. And he sings and she plays guitar and stuff like that. And they have an absolute blast, right? Some people don't like their speech exercises. Cool. We got to make it fun. We actually has a lot of big amplitude movements, right? Tennis, we got a lot of big swinging. Bowling, we got a lot of big swinging as well as baseball. So I don't discount those. They can be awesome for big amplitude movements. Crossword puzzles are a nice cognitive game and Boggle's a fun cognitive game as well. As far as cardio, go to an exercise class together. I have patients whose wife comes to the exercise class, takes it with us. She did multiple rounds with us just so she could do the same thing at home with him that we did in class. She sometimes got more of a workout than he did. Rock steady boxing, very, very common. It's just works on coordination, power, and aerobic conditioning. It's great. Go for walks on hikes. Make sure it's a safe trail. Had to put that in there. Pickleball, of course, I included. Find any kind of cardio sport you love together and do it. And then we are practicing mindfulness. So you're finding support groups, right? Not just for your loved one, for you guys. Create a community of people that will support you, whether that be family, whether that be friends, whether that be through the Michael J. Fox Foundation. You can find people across the country. Build your team. And I included stuff like meditate and finding those good hobbies that kind of let your mind just like take a break, kind of detox a little bit, especially as caregivers. It gets emotionally very draining. And then you feel guilty because you're like, I shouldn't be drained, right? I'm not the one dealing with this, but you are. It is a team. So you're both experiencing everything together. And practice grace, both for yourself and for your loved one, right? That's the most important thing. So we went over all of these already. This is just an additional slide. If you don't use it, you lose it. So if you don't allow them to continue to practice those tasks, they're going to lose the ability to do them. I know I'm going a little bit over where I was supposed to for questions. I'm sorry, we had so many issues with technology and whatnot. So these are just some little helpful tips that you can use at home for fine motor micrographia issues. I love whiteboards. I found the ones that we use to practice handwriting. I use them when my patients are doing balance exercises. I put them up on mirrors. I do everything, right? Super easy. You can erase it anytime and you can practice in all different sets of lines. Big flicks. Big flicks is an LSVT movement that just requires you to explode your hands out. When we are having issues with buttons, zippers, grabbing stuff, you are going to go, hey, let's take a break. Let's do 10 really big flicks together, and then let's retry the task. And it gets so much better. The other fun cue is do it angry. So 10 big flicks, and then zip your coat as angrily as possible. And you'll see a task go from 40 seconds to like 15, 20. It cuts it in half. It's amazing. So big flicks are your friend. Tremor control. That is why everybody gets a stress ball. When our tremor gets out of control, we want to give our hand another signal that's going to help break it. So squeezing a stress ball, or there's a professor that uses a rubber band. And while he's lecturing, he just moves his rubber band. It keeps his tremor under control. So it can't completely get rid of a tremor, but it can help minimize it and block the signal a little bit. The other techniques are grounding, putting weight through your extremity, especially like when we have unilateral symptoms and we're eating and it's just getting out of control. I have a patient tuck a hand under her leg and then so much better, right? It's that grounding. It's putting weight through the extremity, calming things down. Siri was even learning about it. So these are little techniques to have in your back pocket. Posture. You are the one that's going to see it. They are not going to see it, right? So that means when you see your loved one come here, we are tapping the back of those shoulders and going, let's get up tall. Big and tall posture. Big and tall, I say it nonstop, and that's going to become a really big part of your vocabulary. So anytime you see this, it is your job to go big and tall, because leaning forward can also lead to festination, which can lead to falls. So we want to fight that. We want to stay as upright as possible. And freeze breaking, like we talked about before, weight shifting and rocking. Right? If we can unweight one side of the pelvis, we can break the freeze and keep going. So that's the big thing. I see caregivers just grab the patient and pull them. I'm like, no, don't do that. Don't do that. One, it can lead to falls. So you take your hands, you shift their weight. Once they get in a rhythm, they're going to be able to break their own freeze. That's in those extreme situations where they just cannot break it and you need to jump in and help. Weight shift. You tell them to weight shift. If you have to, you help them weight shift. Almost like dancing. Right? Shifting that weight back and forth. As well as when we come up to that environmental trigger, we are practicing big steps. Whether that be we're going to take 10 big steps before we go over the threshold, or we stand at that threshold, we hold something, we do 10 steps over and back, and then go over it. Okay? You guys are going to be the one that's going to notice these triggers. So it's your job to identify them and remind them, because often it gets forgotten. Hey, this is going to be a problem. Let's work on that strategy before we go. find good caregivers in your area, be very, very particular, right? Get someone on your team that's really invested in making sure that we get back to prior level of function as much as possible. Get involved with specific classes, right? I included on the handout a bunch of programs at JFK. The power class where I am in Piscataway, I included the card of my company who does Parkinson specific treatment, and they're all over Central Jersey because they're home care and they're opening their own clinic in Bridgewater. And I believe I included Parkinson's on there as well, which can be online. It's through JFK, and I know there's a national one as well. And they sing at the Patriot Stadium and everything. It's amazing. And practice grace as much as possible with your loved one and with yourself. I've said it a bunch of times because I see people be so hard on themselves, whether it be, I just can't do this today, or I just feel like I'm not doing things right. Take a breath. We have bad days. We have good days. It comes and goes. Be a teammate. So the last thing is, I made a commitment a little over 2 years ago that I wanted to spend my career helping this population, that this is what I'm passionate about, and I want to make a big difference. And after today, you're officially part of my team. So I expect you guys to take what you learned here and to go on and to make a big difference with your loved one and to help educate the people you come in contact with, because everyone that's getting newly diagnosed is scared. And it's the terrifying time. It's not a death sentence. It's actually just the start of a new journey. And as you can see, it can actually be a lot of fun. So thank you so much and welcome to my team. Any questions? Yes, they take all of that. They also take some privatized insurance. It depends on like out of network, in-network benefits. I'm not too aware of all those nitty-gritty. I just show up to treat. But I do have patients that go through that are not Medicare age as well, and they go through their private insurance. But yeah, they handle all that. They make sure all that's clear before they see you. Oh, the question was about one of the handouts for the rehab company about if they take insurance.
So the question is, ever hear of live action role play? LARPing, I believe.
As a treatment strategy?
So yes, as a treatment strategy, they say that there's running around talking and
Yeah, no, I
with
know
foam
what
swords.
I know what it is.
For other people who are not aware of what live action role play is, that's what it is.
I wonder if my foam swords triggered that question, because I do actually use in the video you saw I had foam swords. I'll use them with my power moves. We'll actually do like fencing moves with it. That is an interesting idea. I've never heard of that, but that's a great idea. If you love it, do it.
They said that the video made them think of that, and
Yeah.
maybe for like stage 1 of Parkinson.
Honestly, you could do that up to stage 3. Yeah. Stage 4, you'd have difficulty with it, but that'd be great balance and agility training. That'd be awesome. Yeah, I'm gonna have to add that to my suggestion board.
That was a really great question. Thank you.
Yeah. So the one I teach is an hour and a half. It's if you contact Hannah, she gives you the information because my pamphlet's old, but it runs from 10:30 to 12 on Saturdays. Pending how many people we get like per round, they open more classes. And also the clinic in Bridgewater, they're hoping to open more classes as well. But I am not aware of if JFK has any power moves classes. That's why I started mine. And yeah. Yeah, so that's why the Piscataway one is great, because the other YMCA's, Metuchen doesn't have a Parkinson's program and Edison doesn't have a Parkinson's program. So that's why we started the one in Piscataway. And if anybody wants to come to it, you can always try it for free. That's my deal with the director, is that anybody can come in and try the first time for free, because it is members get a deal, but then non-members have to pay. My goal is to make it free eventually, but I didn't win that fight yet. But you can always try it for free. You can meet the people. I have an awesome, awesome team. Some of them have been with me the entire 2 years. They're great people, and it creates that community. So even if it's not my class, even if it's a class at JFK, you're amongst other people, right? And other caregivers, other families, and you get to talk and you build that community. That's one of the coolest things, is there's no anxiety about symptoms when you're amongst other people. It makes a huge difference. So that's why I'm like, create your team, create your community.
We have another question from the chat. Should these hours be spread across the week, or can you do them all at once?
So ideally we spread them across the week, but 2.5 is the minimum. It is the minimum amount of exercise. I'd love everybody to go out and do a half hour to an hour every single day. Because again, like we said, it's not just going to ride a bike or going to run, right? Cleaning, heavy duty cleaning, doing yard work, all of that fits within exercise. So you have to think of it like that. Going for a walk, still exercise, but everyone should be doing at least like a half hour to an hour a day. If we have a day where we're sleeping all day, I'm not a happy camper because it's going to make our symptoms worse. On days where we want to sleep the most are the days we need to move the most because it will make a big difference.
A follow-up question is, and people should start PT right away in stage 1?
Yes. So you might not see that many deficits in stage 1, right? Those are the people that I talked about earlier where they show up, they're like, I have nothing wrong with me, I'm good. And we might find some balance issues, or we might pinpoint one thing that they need to work on. Cool. And my job is to educate you guys and the patient on the other things down the road that we might need to worry about. So if we start all the big strategies now, we're ahead of the game. We're able to maintain those pathways longer and maintain the integrity of the movement longer. So the sooner you get in, maybe you don't go to OT right away. Maybe you put off speech, even though I don't like when people do that, because I like an accurate baseline. The sooner you get into these people, the better, because they're going to make sure you know what strategies you need to know early on. But PT especially, if you have very little deficits, they're going to teach you what they need to teach you and try to get you in touch with one of these classes, right? Because those classes are going to work on everything that you need to work on. That hour and a half, right, fills up a lot of your quota. Or rock steady boxing, I think, is 45 minutes to an hour. And that's high intensity exercise. That fills up a good portion of your quota. So learn the strategies, and then they're going to feed you into programs where maybe if you don't need them long term, you go for a month and then you go, hey, I'm going to keep up with my exercise and my big movements as much as possible. And then if balance issues come up or if the disease progresses, that means you're back to PT and you learn more strategies. But I'm an advocate for PT like for life when it comes to Parkinson's. You might take breaks, you might come and go, but because it is a neurodegenerative disease, we can justify continuing to work on things because we're preserving function. Our job is to keep your loved one or you as independent as possible throughout the lifespan. Like I told you, stage 1 to stage 5, I'm working. Doesn't matter where we are in that list, I'm working.
Thank you everyone for attending the program online and in person.
I hope you guys found this helpful.